Good afternoon. We have nothing to disclose. Our group has previously reported that pathologic response to neoadjuvant chemoradiation, as quantified by the AJCC scoring system, predicts survival in rectal cancer. As you can see here, patients with a score of 0, which indicates a complete response, have the best long-term outcomes, while those with scores 1 through 3 do worse. We have also shown that statin therapy during neoadjuvant chemoradiation was associated with improved response. A significantly greater percentage of patients on statin therapy achieved complete or near complete response. Here you can see that 65% of patients had scores 0 to 1, as opposed to less than 50% of patients who were not on statin therapy. A popular current approach to cancer biology involves the cancer-initiating cell model, where tumor initiation and maintenance are driven by an epigenetically distinct subpopulation of tumor cells with the ability to proliferate extensively, self-renew, and generate new tumors. These cells have been termed cancer-initiating cells, from here on in this presentation, CICs, or cancer stem cells, and they have been involved in modern approaches to colorectal cancer biology. CICs can be isolated from fresh patient tumors after dissociating the tumor into single cells and sorting for cells with a surface marker CD44, which has been linked to CIC properties. Interestingly, we found that in our pre-treatment rectal cancer samples, increased expression of the CD44 gene was associated with increased resistance to radiation, as you can see in this graph, suggesting a role for CICs in radiation sensitivity. Before making too large a leap into clinical translation, we wanted to take our bedside observations back to the bench to sort out this phenomenon. We hypothesized that CICs mediate rectal cancer resistance to radiation, and also that statin therapy targets CICs and combined with radiation results in greater CIC inhibition. In order to test our hypothesis, we used patient-derived tumor cells, both CICs and differentiated non-CICs. In each case, the interventions included a control condition, simvastatin alone, radiation alone, and a combination of simvastatin and radiation. And our endpoints were cell viability and sphere formation, which is a hallmark characteristic of in vitro CIC function. We started by assessing the effects of radiation alone on the viability of CICs and differentiated cells from the same patient. Here you can see the results in samples from 2 patients where cells were allowed to grow for 5 days after treatment. The graph depicts the relative fold change in viability in each condition relative to control at each time point. On the top of each graph, the black line depicts the CIC population from each sample, which only suffers a limited decrease in viability despite the high radiation dose of 6 gray. On the contrary, the red line depicts the differentiated cells, which are essentially obliterated 5 days after irradiation. These findings are in accordance with the modern theory that relatively radioresistant subpopulations of tumor cells, those CICs, may be responsible for tumor regrowth after therapy. We then evaluated the effects of simvastatin on each cell population. Again, in samples from 2 different patients, differentiated cells, depicted with a black line on the top of the graph, showed no inhibition essentially from 1 micromolar of simvastatin, which is a relatively low concentration. On the other hand, CICs are significantly inhibited by simvastatin. Based on these findings, we evaluated whether the addition of simvastatin to radiation could lead to increased CIC inhibition. In this next figure, CICs from 2 patients were treated with irradiation, either alone or with 2 different dose concentrations of simvastatin, and the viability of the culture cells was measured relative to day 0 through 10 days. As you can see, radiation alone, on top with the black line, resulted in an almost unhindered increase in viability for the duration of the experiment, while the combination treatment was significantly more effective in inhibiting CIC viability, and these effects increased with higher simvastatin doses. To demonstrate that the effects of simvastatin are not limited to cell viability, but also included CIC function, we measured the sphere-forming ability of CICs from 2 patients, a defining characteristic of in vitro CIC function. Here again, the control condition, which is depicted by the blue bars on the left of the graph, of each graph. And then, as you can see, irradiation alone, which is the first red bar, only modestly decreased the percentage of CICs that were able to form spheres. However, the addition of simvastatin resulted in a dose-dependent, significantly enhanced inhibition of the sphere-forming capacity of CICs, indicating that their CIC phenotype was compromised by our therapy. In summary, we showed that CICs are more resistant to radiation than non-CICs from the same tumor. However, the inverse is true for simvastatin. CICs exhibit simvastatin sensitivity even at relatively low doses, whereas non-CICs do not. Simvastatin therapy, therefore, allows targeting the radioresistant CIC cell population to increase the efficacy of radiation on colorectal cancer cells in vitro. In conclusion, the information presented here supports the use of the CIC model in rectal cancer, and combined with our previous clinical observation, is a source of excitement as we plan for the use of statins in both rectal cancer animal models and, more importantly, clinical trials. I would like to thank my mentor, Dr. Kaledi, for offering me the opportunity to work on this project, and the fellow members of the lab for their assistance. And of course, this research would not be possible without the generous support of our society sages that, along with ACRS, funded this project. Thank you.
Any questions? Can you remind me what the mechanism is that simvastatin affects the CICs?
So this is actually an important question that we're trying to address. The theory is that even though simvastatin and all statins are administered in clinical practice to lower cholesterol levels, what we have measured is that the effects that they have, the anti-neoplastic effects that they have, both in colorectal cancer and other tumors, are actually not because of the diminishing concentrations of cholesterol that they cause, but rather other intermediaries that are crucial cofactors in signaling cascades within the cell. So we know, for instance, that RAS oncoprotein, which we know in colorectal cancer in the form of KRAS, needs one of those intermediaries as a necessary cofactor to function. Therefore, once blocking that pathway, KRAS doesn't function as well, and cells that are reliant on this are inhibited.
Thank you very much for your excellent paper. But in the majority of surgical groups, we are trying to reduce the number of patients, including in protocols of radiochemotherapy, radiotherapy. And now, are you suggesting, try to come back to the past using this drug, to try to reduce or to try to increase the pathological complete response? For example, in patients with a T3B or maybe high rectum, you are suggesting, again, is to use this drug with radiotherapy, try not to operate those patients or to operate?
So this would be obviously the ultimate long-term goal would be to find a preoperative neoadjuvant therapy model that essentially reduces the need or even removes the need from surgery, and we can move to a point where we can spare patients their from the proctectomy and all the morbidity that entails. But based on the data that we have so far, we're not in any position near to be able to recommend this for clinical practice, but rather to start working on clinical trials that may show improved response, and if that is true, hopefully extend the parameters of patients that actually receive it.
Thank you.
You're welcome.